Welcome back to the deep dive. You hand us the densest, maybe the most intimidating technical manual you can find, and, well, we transform it into the essential knowledge you need. We help you grasp the why behind all that complexity. Today, our source material is really the ultimate reference, this huge multi-volume set on operative orthopedics. This is the granular, super technical guide surgeons actually use when, lives and certainly mobility are on the line. Our mission, pretty simple, really. We're acting as your personal surgical scout. We're wading through thousands of pages to pull out the really high-stakes, sometimes surprisingly counterintuitive nuggets that govern everything, from basic prep right up to next-gen joint engineering. So we're going to look at why something as basic as a tourniquet needs a special curve fit, why a modern hip replacement has to be engineered to withstand forces up to 10 times your body weight. Yeah, 10 times. And also the microscopic sort of warfare happening inside your joints that can lead to implant failure. Okay, let's unpack this crucial groundwork first.
Right. The hidden start line for any successful orthopedic procedure, it isn't really where the incision begins. It's all that meticulous preparation beforehand. We often focus on the dramatic steps in the OR, but two foundational things, often invisible to the patient, are absolutely vital for success. First, the mechanics of the tourniquet, and second, the precise timing of those prophylactic antibiotics.
Okay, let's start with the tourniquet. Seems simple enough, right? But our sources spend a surprising amount of time just on cuff selection. It seems a bit excessive, maybe, until you realize what happens if you get it wrong.
Exactly. You might think a standard straight rectangular cuff works for everything. But the sources really emphasize that those are only optimal for perfectly cylindrical limbs, which, let's be honest, isn't always the case. If you're dealing with a more conical extremity like, say, a muscular thigh, a curved cuff, it's actually what's needed.
Why does that geometry matter so much? The shape?
Well, because of the curved design, it spreads the pressure more evenly around that cone shape. And this allows the surgeon to achieve the necessary arterial occlusion using significantly lower inflation pressures.
Ah, okay. So lower pressure means less risk.
Precisely. Less potential for nerve or even muscle damage, which is kind of the whole point of using a temporary tourniquet anyway to get a bloodless field, but safely.
Right. And speaking of pressure efficiency, the notes also warn against using too much padding under the cuff. Now, if patient comfort isn't the main driver here, why is extra padding a problem?
It really comes down to physics. The rule established in the literature is basically if you apply more than 2 layers of padding, you significantly cut down the actual pressure that gets transmitted to the limb itself. So if you're aiming for a specific safety pressure, but all that padding is cushioning the effect, you might end up having to inflate it higher than you intended, which sort of defeats the purpose of the careful pressure calculation in the first place. Less padding is actually more effective for safety here.
Okay, now here's a really crucial safety step that seems to challenge, well, years of conventional wisdom. The timing for prophylactic antibiotics. Traditionally, the thinking was the drug has to be in the tissue before you inflate the tourniquet, stop the blood flow. But our sources cite a prospective study with a pretty astonishing counterintuitive result.
Yes, this is a fascinating one. The general surgical belief, for decades really, has been you need to administer antibiotics maybe 5 to 10 minutes before inflation, get it circulating. However, the study they cited found that administering the antibiotics just 1 minute after tourniquet inflation actually resulted in a significantly lower infection rate compared to the traditional timing.
Wait a minute, 1 minute after.
Yeah.
How does that work? If the blood flow is stopped, how does the antibiotic even get where it needs to go effectively? That seems really radical compared to the standard practice.
It absolutely challenges that consensus. It suggests the timing window is maybe more sensitive and perhaps misunderstood than we thought. The sources suggest that might relate to the kinetics of tissue perfusion right at that moment. The traditional view assumes the drug needs time to saturate the limb before blood flow stops. The alternative idea, maybe, is that administering the drug just as the tourniquet inflates might maximize the concentration right where the surgeon needs it in the vascular system that's just been isolated, right before the incision. It highlights that the exact moment might be more critical than we assumed.
That level of detail, wow.
Mhm.
And it extends beyond drugs to just preparing the skin, right? The notes warn explicitly about prep solutions running under the tourniquet.
Oh, definitely. That's to prevent a really nasty complication, a chemical burn. Those skin prep solutions are harsh. They have to be to sterilize. If those caustic agents pool underneath the cuff, under high pressure, it can cause a severe burn. So the standard defense is applying a circumferential adhesive-backed plastic drape just distal to the tourniquet. It acts like a waterproof barrier. protects the limb from the very solutions meant to keep the patient safe.
Makes sense. So once the patient's prepped, protected, the surgeon moves to access. And this brings us to the hyper-specific nature of orthopedic blueprints, these named surgical approaches. These aren't just random paths, are they? They're standardized routes designed to minimize any collateral damage.
Precisely. These approaches are standardized blueprints because, well, the anatomy is pretty standard. They often carry the names of the surgeons who described or perfected them, like the Thompson or Henry approach for structures in the forearm, or the really complex surgical dislocation of the hip described by Gans and his colleagues.
These aren't just abstract concepts, then. They really dictate the margin for error.
Absolutely. Whether you're looking at something like the posterior inverted U approach to the shoulder or maybe the subvastus approach to the knee, these detailed maps, they follow natural anatomical cleavage planes. They're designed with one main goal: provide visualization and access while ensuring vital structures, nerves, major vessels are meticulously preserved. It's anatomical risk management at the highest level.
That meticulous precision is just step one, though. Once we're actually in, we hit the next major challenge. The pure engineering problem of a total hip arthroplasty, or THA. Let's talk physics, because the forces these implants have to handle are just staggering. I mean, when we talk about just walking, it seems pretty low impact, right? But the estimated load on your femoral head just during the stance phase of normal walking is calculated to be 3 times your body weight. And during more dynamic activities, lifting something heavy, running, jumping, that load can spike up to an unbelievable 10 times your body weight.
10 times body weight. It's incredible. That means we aren't just talking about simple material science here. This is like aerospace level engineering applied inside the living, dynamic human body. And that implant has to last for decades under that immense, repetitive, cyclical load.
So what's the biggest threat to that longevity besides just the material eventually wearing out?
Well, a huge engineering challenge is something called stress shielding. Think of it this way. Your bone is actually quite smart. It adapts based on the load it experiences. Now, when you place a very rigid metal stem inside the femur, the implant itself is often much stiffer than the surrounding bone. So this implant ends up taking on too much of the load, which reduces the stress that's normally physiologically transferred to the nearby bone.
So the bone almost panics. It thinks it's not needed anymore because the metal is doing all the work, and it starts to resorb, to weaken.
That's a great way to put it, yeah. Stress shielding leads exactly to that. Adaptive bone remodeling and often proximal bone loss, which can ultimately compromise the long-term support for the implant itself. The key way to mitigate this comes down to material choice. Our sources note that materials with a higher modulus of elasticity, basically, how stiff they are worse offenders. For instance, cobalt chromium stems, they cause nearly double proximal bone loss compared to titanium alloy femoral stems in some studies. Titanium has a lower modulus of elasticity. It's closer to bone stiffness. This means it flexes a bit more naturally and helps transfer stress more physiologically to the existing bone, preventing that sort of panic reaction and bone loss.
That comparison is really key then. Better materials reduce those negative side effects of shielding. Okay, speaking of material interfaces, let's get into the complex modular components. Specifically, the connection between the femoral stem and the head, that famous Morse taper. Modularity seems great, right? You can customize components for each patient. But the notes warn us that this taper connection, even the common 1214 millimeter one, is actually a huge potential trap, because manufacturers don't fully standardize their subtle specifications.
It really is a failure of standardization across the industry. While the nominal size might look the same on paper, 12 millimeters by 14 millimeters, each manufacturer has unique specs for the exact diameter, the length, the precise angle of the taper, and even the surface finish. These tiny differences matter.
But if the size is nominally the same, why is there such deep incompatibility?
Right.
Is it like a patent thing, or are the finishing tolerances just that incredibly tight?
It's the tolerances. Those mating surfaces rely on an incredibly precise metal-on-metal friction lock, basically. The sources are absolutely crystal clear on this. Femoral heads from one manufacturer are not compatible with femoral trunnions of another, even if the advertised size is identical. Mismatching those components even by a tiny fraction of a degree in the taper angle or a slight difference in surface roughness can lead to poor seating, and that facilitates dissociation, tiny movements, material loss, and eventually catastrophic corrosion right at that junction over time.
Wow. That's a powerful illustration of the razor-thin margins in this kind of surgical engineering. Okay, and what about the other side? The acetabular cup, the socket part, how do they anchor that securely into the pelvis?
For modern cementless cups, the primary immediate fixation method is a really powerful press fit. The instrumentation is designed to allow the surgeon to oversize the implant slightly, maybe 1 to 2 millimeters larger than the reamed acetabulum. It relies on shear friction, wedging it in tightly to hold it in place initially. But for long-term biological stability, you need bone ingrowth. And that occurs most reliably near any supplementary fixation devices, like screws or pegs that might be part of the cup design. These act as stable points, anchors, really, allowing the natural bone to grow into and incorporate the cup structure over time.
Okay, so even with perfect materials, perfect press fit, over decades, the sheer volume of movement, of articulation wear, can still lead to complications, particularly this thing called osteolysis bone loss around the implant. I was really struck by the sheer scale of the debris mentioned in the source material, these microscopic particles.
It is a phenomenal scale, yeah. It really illustrates the body's extreme sensitivity to foreign material. Osteolysis is triggered by the host's inflammatory response to this particulate debris. Tiny bits of polyethylene plastic, metal ions, or maybe even cement particles if it was a cemented joint. And these particles are predominantly less than 1 micron in size, really tiny.
That number you mentioned, 1 billion particles per gram of tissue, that's just shocking. What does 1 billion particles that small even look like? Is it like microscopic sand constantly irritating the joint?
It's far, far smaller than sand. Think of it less like sand and more like a pervasive, almost invisible fog or dust cloud at the cellular level. Electron microscopy found these particles are present in amounts sometimes exceeding 1 billion per gram of tissue in those membranes right around the implant. And because they're so small and incredibly numerous, they trigger this constant low-grade inflammatory response. This activates the cells, osteoclasts, that specialize in breaking down bone, leading to that bone loss, the ptosis.
Okay, let's shift focus a bit from replacement towards preservation. The goal is always to catch bone diseases earlier, right? Before the damage gets so bad that you need that total joint replacement. One of the toughest to catch early is osteonecrosis of the femoral head, often just called ONN.
Yeah, early diagnosis is absolutely everything for ONN, because if you can catch it before the subchondral bone collapses, before the joint surface caves in, you have options to intervene and potentially save the hip. For this, the sources confirm that MRI is by far the most sensitive technique, much better than X-ray or even a bone scan in those very early stages.
So what are surgeons looking for in that MRI image? What's the classic sign?
On the T1 weighted images, the classic appearance is described as a geographic region of abnormal marrow signal. It sits within the normally bright, fatty signal of the femoral head. It looks like this isolated sort of dead zone, and it's often sharply circumscribed, outlined by a distinct low signal band. That dark band represents the interface, the reactive border between the living bone and the dead, ischemic bone. Seeing that pattern is key for early diagnosis.
Right. And if intervention is needed, whether it's for ONN or maybe for fusion procedures, surgeons often rely heavily on bone graft substitutes. We should probably nail down the difference between the 3 key biological mechanisms or accelerators used in grafting: osteogenesis, osteoinduction, and osteoconduction.
Yes, this is really crucial for understanding how we try to rebuild or encourage bone formation. Let's maybe use a garden analogy to make it memorable. Okay, osteogenesis is like the seed itself. Actual living cellular elements within the graft material survive the transplant procedure and actively start synthesizing new bone themselves. The graft brings the bone-building cells.
Got it. The graft is the active builder. Okay, what about induction?
Osteoinduction is more like the fertilizer. The graft material contains substances, often proteins like bone morphogenetic proteins, BMPs, that recruit the patient's own mesenchymal stem cells to the site. It signals them, induces them, to differentiate into osteoblasts, new bone-forming cells. So it encourages the body to build bone there.
Right, fertilizer. Okay.
Okay.
And finally, osteoconduction.
That's the trellis or the scaffold. The graft material simply provides a porous structure, a framework. It doesn't actively build or induce bone formation itself, but it provides a pathway for blood vessels and the body's own bone cells to grow into and across a gap. It's a passive scaffold. Now, while autologous grafts using the patient's own bone are still considered the gold standard because they usually possess all 3 properties, many substitutes like helos, which is a mineralized collagen matrix, or vitos, a beta-TCP material, are used. These often rely on a combination of osteoinduction and certainly osteoconduction to help accelerate the healing process.
That's a really helpful way to differentiate those concepts. Okay, finally, let's touch on the philosophy of hip preservation surgery. It's aimed more at younger adults dealing with issues like femoroacetabular impingement or FAI.
Exactly. FAI is a major target for preservation efforts. It can present as either cam impingement, pincer impingement, or often a combination of both morphologies. The whole goal of preservation surgery here is to alter that problematic hip morphology. By reshaping the bone slightly, you aim to allow a full, unhindered physiologic range of motion and hopefully halt or at least slow down the progression of early osteoarthritis that FAI can cause.
And how does the surgeon know they're dealing with FAI? What are the key diagnostic signs or markers they look for?
Well, clinically, a really crucial step is the FADR test. That stands for flexion, adduction, and internal rotation of the hip. Performing this maneuver often produces sharp pain in hips that have symptomatic anterior impingement. It's a strong indicator. Then, morphologically, on imaging, they look for specific structural changes. The classic pistol grip deformity, for instance, is where there's excess bone growth at the junction of the femoral head and neck. This physically jams against the rim of the socket, the acetabulum, when the hip flexes and rotates internally. That jamming is the impingement. Surgeons also measure things like the alpha angle on X-rays or MRI to quantify that excess bone. So preservation surgery, like a periacetabular osteotomy, PAO, or an osteochondroplasty, is aimed squarely at correcting that underlying geometry problem.
We've really covered a huge range in this dive, haven't we? From ensuring a simple tourniquet is curved just right to minimize nerve damage, all the way to calculating 10 times body weight biomechanics for implants and distinguishing between these complex bone graft mechanisms.
Yeah, and if we try to connect all this incredible technical detail back to the bigger picture of surgical innovation, particularly thinking about that discussion around minimally invasive techniques that was popular a while back, we noted that while incision size definitely decreased, many of the early rigorous studies found, perhaps surprisingly, no significant difference in patient outcomes like ambulation or function after, say, 1 year compared to traditional surgery. And in fact, some critics worried that the reduced exposure might even lead to more complications because surgeons simply couldn't see as well to place components perfectly.
Right. So if smaller cuts didn't automatically translate into drastically better long-term outcomes, where does the next big leap in surgical success come from?
Well, I think this raises probably the most important question for the next decade of orthopedic surgery. It's all about accuracy. You see, given that numerous studies show surgeons' own visual assessments of crucial component positioning, like the exact angle and depth of the hip cup and stem, are often surprisingly inaccurate when you compare them objectively with postoperative CT scans. It suggests the next truly great innovation isn't necessarily about reducing the cut size further. It's more likely in technology that eliminates or at least significantly reduces that human variability in placement. So the biggest future deep dive, I think, will involve computer-assisted surgery, navigation systems, maybe even robotics. These systems show real promise not necessarily in shortening the cut, but in dramatically reducing the variability of crucial implant placement, guaranteeing that optimal position more consistently, which should improve long-term mechanical success and implant survival. The real innovation might be in reproducible accuracy, not just incision length.
That's a truly fascinating insight to end on. The next frontier in mobility isn't necessarily faster surgery or shorter scars, but maybe smarter, more precisely guided surgery. Well, thank you for diving deep with us into this incredible, complex blend of biology and engineering that underpins modern mobility.